On Monday, I gave a talk at the paediatric session of BSH, and so the talk was on what aplastic anemia is, and divide it into inherited causes and what's acquired causes. And then we looked at some of the genetic causes of aplastic anemia and how a clinician who's faced with a child with aplastic anemia might go about screening for these genetic causes. So we went through the process and how likely it would be for a child to have a genetic cause for aplastic anemia. And I gave an overview, an algorithm of how to go and screen for genetic causes and when not to do that. We then talked about some of the commonest causes of inherited aplastic anemia, and one of the commonest is something called dyskeratosis congenita, which is a disorder of the telomeres, and telomeropathies are the telomeres are the caps at the end of the chromosomes. It's very important for chromosome integrity, and DKC is a disorder where the telomeres are excessively short. And we talked about some of the novel treatments for DKC. One of the most important treatments are androgens. There's a very important study in New England Journal of Medicine now about 2.5 years ago, which showed that if you give androgens to DKC, you can actually increase the telomere lengths and you can improve the blood counts. And then the next part of the talk was about acquired aplastic anemia, so it's not due to a genetic cause. And then we talked about some of the mutations that you find in acquired aplastic anemia and their prognostic significance. And then finally we talked about some of the new treatments for acquired aplastic anemia. And one of the most important new treatments is eltrombopag. And I talked about, again, another New England Journal paper which showed its response rates in refractory aplastic anemia. And then I talked about another New England Journal paper about eltrombopag in frontline aplastic anemia. And there were several cohorts of people who got eltrombopag, but the cohort who did best with eltrombopag was cohort 3, who got cyclosporin, ATGAM, and eltrombopag from day 1 for 6 months. And they showed stunning response rates over 90% with complete remission rates of 58%, which are unheard of, these response rates. And then we talked about some of the biggest controversies in acquired aplastic anemia. So if you get a child with acquired aplastic anemia, should they get eltrombopag with immune suppression, or should they get transplantation? And so we showed the data for transplantation, which is excellent for matched sibling transplants. But we also talked about what the UK has been leading on, which is matched unrelated donor transplants, and showing how you can, if you can find a donor quickly, can do very effective treatments using matched unrelated donor transplants, and that you can get very effective cure rates with matched unrelated donor transplantation. And so we discussed the pros and cons of eltrombopag versus matched unrelated donor transplants. And then finally, we talked about the UK guidelines, which were published in the BSH, in the BJ Heme, and showed the paediatric algorithm for aplastic anemia, which talked about how we rank between transplantation and eltrombopag. Perhaps the biggest limitation is because it's such a rare disease, the difficulty of doing randomized controlled studies. And so we don't know at the moment which is better, using eltrombopag or transplantation using matched unrelated donors. And the difficulty, because of the rarity of the disease and getting funding to do those kind of really important clinical studies, is perhaps, I think, the biggest challenge at this moment in time.